At the outset, I would like to thank the Indian Society of Organ Transplant, Dr. Sanjay, who's been initiating these online sessions. And it's my privilege to talk about regarding abdominal organ retrieval in uh, scenarios where the cardiac arrest or the circulatory arrest has happened. So I'm going to talk to you about. I'm going to take you through this scenarios, how we can do donation after cardiac death, and what are the surgical technicalities involved in this. So I think the most important thing for any surgical operation is the anatomy. So you need to be aware of the anatomy. So to recapitulate, I've just got some pictures. So this is showing the picture is showing the arterial and the biliary anatomy of the liver along with the pancreas. So we must remember that the liver and the pancreas are very closely interlinked, and when the retrieval is happening, so these are the arteries. They're all supplied primarily by celiac axis. The liver is primarily supplied by celiac axis, whereas the pancreas has a dual supply from the celiac axis and from the SMA. Rarely you can have aberrant arteries. You can have one artery going from the SMA as an accessory right hepatic, which follows close to the bile duct, or sometimes you can have an accessory left hepatic, which is there in the lesser omentum and which can be a branch of either the splenic artery or sometimes the left gastric. So you have to be aware of these anomalies. With the kind of expertise we have, we can still do these transplants. And so, for the anatomical perspective, this is the gastroduodenal artery. This gives the superior pancreaticoduodenal. There's an inferior pancreaticoduodenal coming from the SMS, which form the complete target, and the GD is ligated here, and the liver is taken. The three branches of celiac axis: the left gastric, splenic artery, and the common hepatic. So these are the three branches. Splenic goes with the pancreas, and left gastric is retained in the recipient, in the donor itself, whereas the common hepatic follows the liver, along with the patch of aorta going down to the root of celiac axis. So this is about the pancreas. When we're taking out the pancreas, so we always have spleen along with the pancreatic tail, and the C loop of the duodenum along with the body and the head of pancreas. Uh, this pancreas is supplied with a portal vein. The celiac trunk is actually left behind, and we only get the splenic artery here, which is cut here. The hepatic artery goes to the liver team, and the GD is ligated here. The superior mesenteric artery is doubly ligated. One is at when it follows down the head of pancreas, and second is at the origin. That's where it is cut from the aorta, and then these are reconstructed in the recipient. So having a knowledge of anatomy is very important. And when we are talking about the DCD, so we need to be very sure that we do not injure any accessory or the abnormal arteries. So there the role of anatomy even is more important. And as far as the kidneys are concerned, the kidneys, we are all aware that you have polar arteries, so they can come from anywhere of the in the aorta. You can have early bifurcations, but the most important challenge here is you sometimes can have a polar arteries coming originating from as low as iliac. So my uh, tip for all the younger surgeons is that when you are doing a donation after circulatory arrest, when there's a rapid retrieval happening, so always cannulate the iliac vessels rather than the lower aorta. If you cannulate the lower aorta, so this pole is gone, and if you injure the lower polar artery, your vascularity of the ureter might be compromised, thereby spoiling the entire effort, right? So be aware of the anatomy. And before I tell you about the surgical steps, why DCD, right? So we've all been focusing throughout the time period on the DBDs, whereas we know that the DBD is potentially only about 30% of the pool of donors. If we expand into DCDs, the circulatory death, we all die by most of the deaths happen by the circulatory mechanism rather than the head injury or a brain tumor or a stroke, right? So majority of deaths happen by the cardiac mechanism. So that is why this has certainly become important. And worldwide, it's now about 20% of all donations happening. And in some countries like Spain, UK, and now even the US is joining this 50%, which means that about 50% of current organs are being retrieved from donors with circulatory arrest rather than patients with the brain death. If we talk about India, I think we have a donation rate of less than 1 per million population, so it is extremely low. So we have to be focusing on all possible avenues where we can increase this rate. So why are the two different? The two are different because in donation after circulatory determination of death, which is called DCD, as compared to D and DD, which is donation after neurological determination of death. Here, the time is of a sense, right? So your heart is no longer pumping, your organs are no longer getting oxygen. They are not able to generate their ATP, so they go into phase of warm ischemia. And we know that warm ischemia times are limited by the organs. So if you have a kidney, you probably can tolerate a warm ischemia insult of about 2 hours. For liver, it's probably 1 hour, and 30 minutes probably better than that. And for heart and lungs, the same situation is there. So that is why if once your circulation stops, you have to get the organs out as early as possible, unless with the newer technologies what we have been able to develop, you are able to reperfuse these organs. So the whole point here is that the circulation should not stop for a long period of time. So so there have been different classifications regarding how can we define these patients with the circulatory arrest, and why is it important is that you can categorize into uh, two broader categories, which are controlled and uncontrolled. And controlled and uncontrolled means that depending on whether you are in control of the situation. So if you know that okay, this is a controlled situation, you know that death is going to happen. The heart is going to stop in a particular period of time. So we call it uncontrolled. We call it controlled. The uncontrolled is that when you don't know, suddenly you get a news that oh, there's a patient whose heart has stopped. Are you willing to take organs? So that's an uncontrolled situation. One of the situation is where you have a semi-like a thing, that a control, and where like you have a patient who's on a organ donation pathway who's brain dead. His family is already consented, and he's going to test it for his presence of brain death by the apnea test, and in between he has a cardiac arrest. So that we call it as a control because the patient is already in the ICU, the pathways have already started, and so the situation is not as perilous as a patient who's coming into the emergency and is dead on arrival. All said and done, even these category 1 and category 2, where the patients are actually do not have any heartbeat at the time of either arrival, or they do not, the heart refuses to initiate circulation while in the hospital. So all these categories, the organ donation does happen across the country, not across the country, across the globe. We've been able to do unexpected cardiac arrest, the category 5s, the category 4s, and category 3 in our own institute at PGI Chandigarh in India. And there are other centers which have been able to replicate this. So all these are possible. The only trick is to learn the correct surgical technique for it. And we have our ICU resources at the moment are really stressed all across the country. Many anesthetists are not aware how to manage these patients with brain death, where there's a major storm developing in them, and they do end up in cardiac arrest. And if your management is not up to the mark, so you may lose about 10 to 20% of these potential donors by potential brain dead donors by a cardiac arrest. Uh, if you know the correct technique, the correct method of retrieval, these all can be salvaged. And then there is a controlled pathway which we are yet to start in our country, except for an isolated instance happening in Manipal and a couple of what we have done at PGH Chandigarh. Control is when you actually withdraw life support. So withdrawal life support is been very controversial across the country, but fortunately, the Supreme Court has touched this the pathways associated with it, and three legislations across the last decade have really made this very clear as far as whether you can actually withdraw life support or not. And the recent one was where one of the patient, the nutrition was withheld to allow him to die after spending more than 13, 14 years in a vegetative state. So, with the control life support, with the control DCD, so you need to have these terminologies imbibed into your mind. Why these are important is that you these some things you actually cannot. So your warm ischemia time and the functional warm ischemia time. So functional warm ischemia time is when your systolic blood pressure is less than 50. So that is that duration we consider that the organs are getting ischemic damage, and that time should not exceed, as I said earlier, 2 hours for kidneys and possibly an hour for the liver. Then there is something called an agonal phase, which is talked when more in an intensive care setting. That starts from when you withdraw life support until you declare death. There's a period of no touch time. No touch time that means that when you have an asystole happening, so asystole happening, you should wait for 5 minutes. You just cannot start your retrieval process at the same time when your asystole has happened. So you have to give 5 minutes period, determine death, make it irreversible, and then only you start your cold flush or whatever you want to do. So these times are important because you have to restrict to these limits, and there are more terminologies as we discussed. DCD is donation after cardiac death. Better terminology is donation after circulatory determination of death. Non-heart beating donor was in the initial days when these things were introduced. At that time, they said the heart beating is the one where there's brain death, heart is still beating, and the non-heart beating is when the brain is there, but brain is not there, but the heart is still beating. Uh, and non-heart beating are the DCDs ones. The NRP is the normothermic regional perfusion, where you can actually reanimate the circulation, either the abdominal, which is called the ANRP, or the thoracoabdominal, TANRP. Mastic classification, we already discussed. The DBTL catheter, we'll come to that later on. And these are the ischemia time, warm ischemia, cold ischemia, functional warm ischemia, we already discussed. So all these are fairly known to the transplanters. No touch period we already discussed. That donor rule is that your act of organ donation should not lead to death of the donor, which means that you just cannot start the organ retrieval which leads to death. Means that you should declare the death before you start any procedure. Although we do some antemortem interventions, but none of the antemortem interventions should lead to death of the patient. So confirmation of death, these are the golden criteria. So absence circulation for either by demonstrating by a patent arterial line which shows a flat line, or by an echocardiography, or asystole on an ECG. So all that for a period of at least 5 minutes to establish that it is irreversible and the patient cannot have a spontaneous recovery. This is very important. So retrieval technique would vary, as I said, that will depend upon the situation. So you will need a rapid retrieval when you have a uncontrolled DCD as per the Maastricht criteria. You can have a standard retrieval as you do all of them, especially if you have an ECPR protocol in your place, or if you have an NRP thing going on. So both of these are at the moment not widely available in the country. ECPR is picking up very fast, and we've had at least one instance of organ recovery following NRP. The US scene has changed dramatically over the last decade by this NRP. We'll talk about it in my later slides. And then we need to know about some antemortem interventions, especially when you are contemplating withdrawal of life care, where you can actually put some catheters or cannulas in your femoral arteries, which can rapidly cool the patient once the cardiac activity stops. And then there's a role of NMP. NMP is normothermic machine perfusion. So that's I'll just present a case regarding that as well. So that's a standard retrieval. So if we talk of the uncontrolled DCD. So we have super rapid technique. Super rapid technique means that what you have to do is you do not have to do any dissection. What you want is that just do a simple kettle brush that takes about a couple of minutes after opening the incision. Give a midline from xiphoid to pubic symphysis, so you don't have to worry about any diathermy. Just open with sharp blade or scissors, whatever you have, and a simple midline incision. Do a kettle. Ask your assistant to just detect the the muscles onto one each side, and then try to identify the distal aorta or the iliacs, right? So once you've done the kettle press, you just lift all the bowel onto the left hypochondrium. So that's going to give you very good exposure, right? So either you can circulate the common iliac on the right side, or if the patient is thin and lean, you can easily get to the distal abdominal aorta. So once you have done that, you can actually put a catheter and you can start the preservation fluid. So typically that shouldn't take more than 5 minutes in any situation, right? So you have to be prepared, your team has to be prepared. So it normally shouldn't take more than 5 minutes for it. Some people would prefer to cannulate the IMV, so especially in a DCD type of situation. And once the cannulation is done, you just start with the perfusion fluid, and once the perfusion fluid is started, then just fill the entire abdominal cavity with ice slush. And once you've done this, then you just split up in the sternum, and thoracic aorta can be cross clamped by opening the thoracic cavity and retracting the lung onto one side. You just feel the descending thoracic aorta, put a vascular clamp on it, and you can open the pericardial cavity, the IVC, and can decompress the organ. So once you give about 2 liters of fluid, your liver starts to feel cold, and once it is palpably cold and free of blood, you can actually start your dissection. So the 2 liter is not something which is absolute. So you sometimes may, when you initiate this perfusion, your controls, the upper controls may not be obtained immediately. So you may actually end up giving more than that as well. So we've sometimes used up to 6 to 10 liters of fluid. So it all depends on how well they blanch and how well the upper control is. So if the upper control is not there, so the fluid keeps on going to the entire body. So once you have ensured that the liver is okay, your bowel is well perfused, free of blood, clear, the effluent is clear, then you do the liver removal first, followed with pancreas, and then the both kidneys. So you can do an en bloc removal to have a quicker thing, or you can just do one by one. So these are some of the uh, things which can actually make your life much more easier rather than trying to obtain a lower and upper control. So if you put a double balloon, triple lumen catheter, so what you do is that you push this catheter through the iliac arteries. That makes your life very easy. Within 100%, within 5 minutes, you are able to establish the cooling of the body, right? So you push this catheter inside, inflate the lower balloon, pull it back. This balloon goes and gets stuck at the aortic bifurcation. Once it is there, the aortic bifurcation, you inflate it more so as to occlude the lumen of the aorta. So initially you just put 3 ml of saline, and now you're putting 10 ml of saline. So once you've done that, at about 10 centimeters up, there is another balloon which has got a separate lumen catheter to be filled up, and then you just fill it with another 10 ml of saline, and then this is there are openings here inside this catheter, and then this can be used to reanimate cold circulation inside the abdominal aorta. For abdominal organs, this works pretty well. You get a 100% recovery of organs if you are well within your technique here. So this is another pictorial diagram that you've got a cold perfusion fluid here, which you can start perfusing from here. So these are the two balloons which are inflated. The suprarenal aorta is occluded here. This actually goes inside the, mostly this is inside the thoracic cavity. You can actually confirm it if you have a CM in the OT, but or you can actually just you can actually, before you insert, you can actually measure the distances on the recipient as I had shown on this slide. So you know that this is definitely going to go into the aorta. So, and when the balloons are in place, then this is getting perfused. All organs are getting perfused, and the effluent can be still drained from the venous side. The IVC, you can put another catheter. So these catheters can also be placed while the patient is in the ICU, but then there are concerns, ethical concerns, whether you should be putting these when the patient is in ICU or not, because this may harm the patient. The short of it, you can actually put your arterial sheaths. So once you have an arterial sheath, you know you have an access there, and that can be used to then place a guide wire, and then these balloons can be pushed over the guide wires on the bedside as well. So this is another intervention which is there, which can be used very well. So we know that when the circulation stops, you have issues with it. So this is in one of our situations where we did it, and so what it does is that it keeps on pumping blood to the organs, and with that, you actually you are having some supply restored to the organs, so which helps you to maintain some perfusion. So it's not a functional warm ischemia. The ischemia is there, but I'll show you in my later slides that this helps to better recovery of kidney function at least. So, but this is for uncontrolled DCD. So when we're talking of other thing is the abdominal normothermic region perfusion. So so here the same balloon is there, and the circulation, it's no longer the cold saline, so it's normothermic, means that it's oxygenated normothermic. You have a pump here, and the pump delivers oxygenated blood which goes to the aorta. So what they have shown is here is that okay, you've got one catheter here in the iliac artery, so that is supplying the blood. You can put another catheter which has, I mean, the double balloon is not commonly available, so you can use these catheters, the aortic balloons. So this the aortic balloon can occlude the thoracic aorta, and once you have these two balloons in place, you can start the circulation, and again the blood returns through the IVC, which goes to the pump, and from the pump it goes to the oxygenator, heated up to body temperature, and then returns. So what the advantages of the NRP are that all organs become functional. You can assess their function on the on while operating. So it has helped to recover more liver specifically from donors with the circulatory arrest, and has reduced the primary non-function, the delayed biliary complications, the strictures, and if you have abnormal anatomies, they are more easily usable, and it makes this procedure an unhurried procedure. It makes the donation from a nighttime to a daytime procedure type of thing. But there are drawbacks. So obviously, it's costly. You need a lot of manpower, and the equipments and all are pretty expensive here. So this the other thing what you need to know is that many times when you're doing such kind of retrievals, you know about the times and all, and you end up with organs which are poorly perfused. So what do you do in these cases? So in these cases, you have another technology now available, which is called the NMP, and you should always put these organs on NMP for assessment if you have any doubt that these organs may not function right. So these kidneys, when it was put on the machine, and within 20-30 minutes, it became like this. So definitely this organ is not to be used. So these are the standard criteria. So anything beyond the standard criteria, more than 2 hours of functional warm ischemia, or there's a difficult retrieval, there's a patchily perfused organ, or you've got an anticipated CIT of more than 6 hours. So any of these, if you tick any of these, I think should probably go for an NMP. This is one example of NMP where the functional warm ischemia was more than 7 hours. So BP was of the patient was less than 50 for more than 7 hours. Systolic BP less than 50 for more 7 hours, but the kidney was still making some urine till the last couple of hours, which made us believe that okay, so some flow is going on. The kidney is still surviving this kind of functional warm ischemia as well. You put this kidney on the machine, it started to make urine on the machine, and you see these perfusion parameters the perfusion time of 190 minutes, and all parameters started to improve, and this kidney was successfully transplanted. So with that, I'll just probably come to this one of the case capsules which you probably have seen in your situations as well. 30 years old male, road traffic accident with head injury, E1, VTM1. He ended up in a busy emergency. I'm sure all public sectors are like this only. Had a cardiac arrest. He was revived, started on inotropes. Family was told about the situation that this is severe head injury, devastating head injury, and there's no chance of revival here. The family initiated talk of organ donation, and but the it was difficult to. I mean, he was shifted to the ICU, but it was very difficult to sustain his blood pressure and has another cardiac arrest. So what do you do in this case? So most of patients will actually this is will say that okay, we can't do anything now, just leave it. So while in the ICU, so this is the timeline. So you have to note on the timelines here when you have a cardiac patient with DCD. So the timeline 3:14 p.m. your mean arterial pressure falls to below 50. So that's the start of functional ischemia. The patient gets a flat line in the ECU, which is at 3:28. There's a no touch period of 5 minutes. 3:33. The patient is shifted to OT, and within 4 minutes, the cold position could be started. So it takes only about 4 minutes to for all that happen if you are quick enough. So, and this is the kidneys which we could retrieve afterwards. So the surgeons sitting here can notice that okay, the color of kidney is not great, so they appear to be patchily perfused. Uh, because the he's had multiple arrests, so we're not sure whether there's some clotting or whatever has happened in the kidney. So these kidneys are put on the normothermic machine perfusion. So the picture now, what you see is that these kidneys are being perfused. The color is not as bad as we saw in the last picture, where I'll just go back there. Not like this one. And this is about at about 4 or 5 hours after transfusion, after putting them on the machine. And this is the oxygenator. You see that what the and these are the this is the machine which shows that the blood the what you probably can read it, that it's been running now at about 10 hours now, and at the temperature 34 degrees with a flow of 490 and the temperature 35 degrees. So with functional warm ischemia time of 45 minutes, which is acceptable for kidneys, normal thermic machine perfusion of total of for 15 hours, and a patient whose the donor's admission creatinine of 0.8, but before the CPR was 6.5. So this type of kidney normally would be refused unless you have these kind of technologies available with you. So the recipients were informed of the condition that this patient has had a cardiac arrest. He had AKI, severe AKI, but he has got a good flow on machine perfusion, which means that the kidneys are going to work. So finally, after going through the list of maybe 10, 15 recipients, so a couple of them who were waiting for more than 6 to 9 years on dialysis, so they agreed. So the interop surgery went uneventful. Both had a DGF given the time that had elapsed and the pre-existing AKI. And ultimately, one recipient could achieve a creatinine of 1.37 at 6 weeks, and the second one a creatinine of 1.9 about 6 weeks. So with that, I'll share our data, what we have done so far as far as DCD is concerned. So this is the data which we published, where we showed that if you do some sort of CPR, the auto CPR, your kidney recovers much earlier, so about 13 days earlier than and you have a higher incidence of cortical necrosis. So this is a patchy cortical necrosis. It's not that the entire kidney is gone. So you may have some arterioles or some vascularity which may be damaged. So that is why we go for in this situation we always go for patients who are the donors who are younger. So we do not do uncontrolled DCD in somebody who's going to, where the donor age is 65 years. But if you have a mean age of 29 years, these kidneys will recover despite having some cortical necrosis. So most of these kidneys would recover. And this is the long-term data till 2020. We've done 19 donors. So two category 3, and most of our categories 4. So if I just show you the outcomes, I mean, the creatinine discharge, the mean creatinine discharge is 1.5. And the length of hospital stay is quite extended because we keep them in the hospital till their dialysis dependent and their kidney function is started to recover. And that is so that is 1.5 is at the time of discharge, but if you see afterwards the GFR continues to improve, and this is data from the long term where we have shown that even at 10 years, 9-10 years, they maintain excellent kidney function. And these are survival estimates that, except for 2 patients who had primary non-function, which happened when at the time when we did not have these machines with us. So 1 year, 5 year, and 10-year graft survival are probably as good as the DBD ones. So, can we make DCD as the standard of care? So yes, we can. I think probably something wrong with the slide. So with that, I think I'll come to the end of my talk. Thank you very much. And again, thank ISOT for giving this opportunity to me. And I'm happy to take any questions. Thank you very much.
Thank you, Dr. Ashish Sharma, sir, for such an elaborative, comprehensive, and stepwise talk. You have explained very well all the surgical steps, and I am sure it has benefited all of us. Thank you very much, sir. Now I invite Dr. Kumud Dittal, sir, to present a DCD heart and lung retrieval steps and TANRP. I request Himanshu ji to please help us to start the talk.
Mine's recorded. I'm happy to do it
Yes.
again if you haven't got access to it.
Yes, yes, yes. Yes, sir. We'll starting, sir, record.
Okay, thank you. Okay, good evening, everybody. I'm going to take you through this talk on DCD heart and lung retrieval, and I'll be mentioning both the direct procurement and the NRP techniques. We'll go through a little bit of background, a little bit of history, outcome data, and where the issues might still be, and how we might best be able to translate this into the Indian context. So we have to go way back, almost now coming up to 60 years, when the first heart transplant took place. And that was a young 25-year-old girl that was walking across the road, got hit by a car while she was crossing over to go to the bakery. And Christian Barnard transplanted her heart into a 54-year-old man with cardiomyopathy, Louis Washkansky. And of course, then he survived 18 days, and you see on the right-hand side, these are all from the Grudge Museum. The top is the Washkansky's original ventricle dilated, and the bottom is the explanted heart, including the transplanted one. And of course, there was a huge resurgence. Everybody wanted to do a heart transplant at that time. It was all going well, and including in India, where Dr. Sen did what was the 6th human transplant. He was a 4th surgeon to attempt, and although it was an unsuccessful surgery, it was part of that early vigor to try and establish this as a clinical therapy. And of course, things were looking even better. And this sort of thing was being bandied about in South Africa. And unfortunately, there was a tragic outcomes, because really the immunosuppression therapy wasn't that great. And so it really left the scene. Very few centers were continuing to do it. The British government banned it altogether. And Norman Shumway, in particular in the US, continued doing this research. And of course, as well as Dr. Barnard in South Africa. And now we know it's a gold standard therapy for people with advanced heart failure. And if you survive the first year, then of course the outcomes are exceptionally good. But donation rates have never really come up to match the number of patients on the wait list. And this is why we're having these discussions as this evening. And we've been extending and expanding our donor pool by relaxing all the previous exclusions that we had. And finally, we're entering to that arena where, as you can see, we're looking at ex situ organ perfusion, the use of DCD hearts, and now including the use of hearts with donors with hepatitis C positivity. So I won't delve into all this master criteria that you will all know about, but currently, mostly the transplants out of DCD are happening in the awaiting cardiac arrest, the controlled master category 3. Of course, it can be done in some category 4s, but they are exceedingly difficult to do, including category 1 in Madrid. And they had an initial cohort that were doing moderately well, but that program is pretty unique in that not many are doing the dead on arrival, as it were, or continued resuscitation from the sign of unwitnessed arrest. And the controlled DCD versus the uncontrolled one is here. You can do a timed, planned withdrawal of life-supporting therapies, and it's all in a very validated process now, where you wait until asystole, and you have typically now an accepted 5-minute no-touch period before you do the organ preservation and retrieval components. While in the uncontrolled one, of course, there is a priori circulatory arrest, and then you're resuscitating. So either have failed resuscitation or the patient is arresting post declaration of brain death. And the reason I'm going a little bit back in history is that very first heart was co-located. So donor recipient were co-located, and it was a DCD heart. They'd already pretty much opened the recipient and were ready and waiting for the heart to stop in that young girl. And then years later, the Denver group came up with 3 good outcomes of neonatal heart transplants from donors that had anencephaly. And then finally, when I was at Papworth Hospital in just before 2009, we were very excited and interested in doing the DCD heart transplantation, particularly my senior colleague called Stephen Large. And it took him years to get permission to do this. And we had a research protocol whereby we wanted to see if this was going to work. And this was the first case that we then wrote up with Ayaz Ali, who was the registrar then at the time, and Paul White, who is a biomedical engineer, now professor at Cambridge in biomedical sciences, and Steve Large and myself there, where this lady in the 50s arrived 17 minutes post withdrawal of life support, is declared deceased, and then gets rushed to theater. And I was doing this with Ayaz, and I remember we did knife to skin, and within 4 minutes I'd put her on bypass, and the heart started beating spontaneously in sinus rhythm. And as you can see from here, this is how bad it was initially. And you will see that is the monitor is showing you when we weaned off to cardiopulmonary bypass, and the heart is on its own. Intestine is moving, the liver looks beautiful. And it was my baptism of fire, thinking that these hearts are definitely going to work. And you can see there piezoelectric crystals that we use to measure pressure volume loops, all very complicated. But this was the proof that we thought was going to launch the programs. Then, of course, the machine perfusion is not new. In Christian Barnard's own unit, these 3, Wickham, Cooper, and Nowitzki also of the fame from the physiology of brain death, had designed their own machine that actually took on airplanes, completely driven only by air, and did a few transplants, but never in the DCD setting. And of course, this fellow, Walid Hassan in Boston, did his PhD in trying to find an ex situ perfusion technology, and discovered that blood-based perfusion was better than anything else. And then eventually that became the Transmedics device that I had used for many years, where the heart essentially is in this box. You can transport it in normothermic perfused. So The technique in Papworth, Cambridge was the direct procurement. I mean, it was the NRP, where we put the patient on bypass. Now we can do ECMO. And that allows the heart to reanimate in the body of the donor, but you have to clamp the head and neck vessels to make sure no blood flows into the brain. And that was dictated by the Royal Colleges, combined Royal Colleges of Medicine in the UK. And so when I went to Australia, I could not do that because in the Australian Declaration of Death and definition of death does not allow you to restart the circulation in the body of a donor in whom the death has been due to cessation of circulation. It would be like putting into question the very certification of death, and therefore, in theory, if the heart restarted as it typically does and you took it out, you would have committed first-degree murder. We then did extensive studies as a 4-chamber pig heart model, and finally used the Transmedics device. These are a whole lot of PhD students who are associated with myself and Dr. Peter MacDonald to try and improve the length of time that would keep the heart outside in terms of tolerating cold ischemia, and how to prolong the tolerance to warm ischemia. And of course, that led eventually to transplanting this lady at the bottom right and her husband in 2014. She was the first one to receive the DCD heart, but had already had her son, who'd already been transplanted before. Unusual to see the mother bringing in this younger son who's already had the transplant. And that quote from Christian Barnard is very much how patients feel when they're up against a difficult decision to make. So just to show you, these are just a couple of tables coming up to show you how across the board, whether there be single, anecdotal, multi-center studies, that the DCD heart survival figures are exceedingly good. And 5 years at 73.9, and the latest figures from Sydney using the direct procurement is suggesting a 65% survival at 10 years. So what is TNRP? TNRP essentially is thoracoabdominal NRP that can be done either through the thoracic sternotomy and accessing the aorta and the right atrium, or it can be given peripherally, and either with exclusion of thoracic organs or inclusion of both, depending on what is being taken. But the concept still requires a cerebral exclusion, which for me personally is an issue, and I will come back to that in just a moment, because there are some ethical issues why, in fact, this is not even happening where it started now in the United Kingdom. So heart outcomes are very good with TNRP, excellent survival, excellent utilization rates as we become more comfortable using it. And again, just to reiterate the survival figures and acceptable rates of PGD, no different from direct procurement between direct procurement and and TNRP and brain death donation as in historical practice. You'll see here is the use of ECMO circuits now in doing the same thing instead of cardiopulmonary bypass. It really makes it very cheap. But in the first couple of these major studies, what we found was the lungs were not being utilized very well. This is from the DCD registry. And there was a question about why the lungs weren't being utilized. Suffice to say, that is no longer the case. And if you do have a proper protocol, which I'll briefly describe, then the lungs can be taken very easily. I'm not showing you much about lungs because we've been using, when I was in Australia, DCD lungs without any machine. You do not need a machine. You do not need anything at all. You can just go and retrieve those lungs and use them, just bring them back in normal preservation, bring them back in your icebox, and they work exceedingly well with the first series in Australia, multi-center, showing survival at 3 years of over 90%. But there are certain things I will assume now. So in terms of the protocol of what you do for thoracoabdominal NRP, these things I'm going to assume that are all in place. So rapid sternotomy, laparotomy at the same time, open the pericardium. You have to identify the head and neck vessels. You can tug on the aorta, pull it down a bit. You put a 2-stage venous cannula in the right atrium. If you're using an ex situ machine, you would drain sufficient blood to prime the circuit. And then you cannulate this ascending aorta, commence your TNRP. The heart typically will start spontaneously and occasionally requires DC cardioversion. But you need to put in a root vent, both for monitoring the blood pressure and also as a vent if you need it. And of course, you then start putting in a Swan Ganz because you're assessing this reanimated heart in the body of the donor with the head and neck vessels clamped. Now, there's some parameters that you need to follow, which are that you're getting lab values and these tests every 15 minutes. FiO2 should be low, and then you're measuring the SvO2 and the PCO2, so you can titrate your ventilatory settings to get those specific oxygenation and CO2 levels, normothermic with a decent hematocrit and a pump flow that is sustainable. However, if there are any issues, it's taking more than 10 minutes to restore that circulation, then you should abandon and go directly for a direct procurement, or in the abdominals, what's called a super rapid retrieval. The lung procurement does require you to be reintubated, of course, a single breath, and then you start that ventilation once you've clamped the arch vessels. Again, fairly straightforward, allows you to do bronchoscopy and the standard pneumoplegia, but you need to put that in to vent the heart and the lungs, because what was happening is in the standard, without this venting of the PA, then you are getting congestion in the lungs. And so this is really critical. And of course, you can have an LV vent as well to safeguard the heart. You run it for 30 to 45 minutes, make sure the perfusion is fine, and then you wean it off. You avoid inotropes, try and get to these various physiological requirements. But again, if you cannot achieve the blood pressure and it's taking you longer than 5 minutes, or organ perfusion is very poor, and you can see that in terms of basic function macroscopically, then you have to reinstate the TNRP again and reassess after a period of time. However, at 2 hours, you should by then have either retrieved or abandoned. Peripheral can be done via an intra-abdominal aorta to IVC or FEM-FEM, but you again need to cross-clamp the thoracic aorta, either at the level intra-abdominally, just below the diaphragm, or using an endoluminal thoracic aortic balloon. Because you do not, in that instance, want the lungs to be flooded, nor do you want the heart to be reanimated. But heart and lungs can still be procured. Hearts rarely, but lungs most certainly. You just need to put in a couple of ICDs, cold Perfidex infused to keep them cool, even in the context of failed CPR on the wards, to buy yourself time. Leave these ICDs in, clamp them once you put the Perfidex in, and it buys you a few hours. You can then take it to theaters as per the other organs and take the lungs out with no further ado, and just preserve them in as you normally would and bring them back on ice. If the heart's being taken in this peripheral cannulation method for NRP, then you have to do the DPP method by excluding that part of the circulation. And so there is no harm to lung outcomes or to the utilization of the lungs if they're done appropriately. And now the UNOS registry is showing good lung utilization, and the outcomes are the same as with direct procurement. So simply here, in terms of the direct procurement and the TNRP, which is the Cambridge Protocol, that's the difference. You will know. I'm not going to go through all of that. You can read it. But there is an ethical issue there, as you can see. And what's happened since then is that Cambridge is no longer allowed to do the TNRP method anymore. And Canada has, after a big consensus study, also decided to ban that. And there are only 4 states in the US that are, I'm not sure if any more have been added recently, but that was the state some time ago, that only 4 were allowed to do this NRP technique with head and neck vessel occlusion. And the ethics was, even when we did that original series of transplants, the ethicists were up in arms, saying that Peter MacDonald and myself probably ought to go to prison because we had gone against the dead donor rule. But of course, what people don't realize is if that is true, then we've been practicing and utilizing DCD, livers, kidneys, and so on for many more years. And so we've broken that rule a long time ago. the issue about the cerebral circulation is, what is the problem? Why are you saying that if you allow that blood to flow, that the brain would come back out? But more importantly is that by clamping the head and neck vessels, you're essentially turning what was a DCD into a DVD, because after a few more minutes of no flow to the brain, you'll definitely end up creating a DVD kind of situation. So are you causing brain death? So that throws a bit of a confusion into that certification, particularly if you reanimate the organs in situ. So from my perspective, it would be far simpler not to clamp the head and neck vessels, except that the patient is dead, and therefore there's no argument about that, as it already has been certified, and you just do a normal perfusion with no exclusions of blood flow. But I know this causes some angst amongst some of the clinicians. So now our techniques are direct procurement, or TNRP, and I put the icebox in because things are shifting a little bit now. So for the lungs, you do not need fancy machines. The fancy machines are useful if you need to resuscitate the lung beyond, what you're getting doing the retrieval. If there's still some edema and so on, yes, by all means, use it. Expensive, but you can do it in a cheap version as well. The Transmedics is exceedingly expensive. It is not the way to go in India, certainly, but we can utilize TNRP. I think in India would be very safe. And it has already been done recently in Dwarka, and they've utilized the liver and the kidneys after withdrawal of life support in a controlled manner. But teams in the US are now doing a direct procurement with slightly different preservation, with a different solution, and putting it and transporting on ice, circumventing that entire cost of the ECMO, of the cardiac heart-lung machine, of this portable device, and so on. And they seem to be having good results. The trouble is that there could be negligent issues later, because you have not done the due diligence to make sure this DCD heart is actually showing functional capacity. But we'll just keep our eyes open, because that seem to be happening. If that happens, and there's a good data coming out, we have good cohorts, then after that, this may be the way to go. And machine perfusion may only be there for extra resuscitation in specific centers that may be doing this for a wider group of facilities that want to utilize DCD organs. So at some point, the big confusion about definition of death must be resolved, I think, and we need to understand what it means in terms of whether the individual is dead or whether organs are dead, because the organs and tissues die at different rates, and this is, again, something that is very majorly misunderstood. So as a last thing, just to put this up as a slide of TNRP versus direct procurement, and trying to balance what is happening with clinical innovation and ongoing medical ethics that are really hampering our clinical, I think, advancement, because we're a little bit in limbo as the Cambridge unit is finding itself in the country where it actually started. It itself is not allowed to do this anymore because of the issues surrounding the clamping of the head and neck vessels. But suffice to say, I think the TNRP technique is ideally suited to India, because it allows you to use a very cheap in situ reanimation, extracorporeal circulation, with the use of a modified ECMO circuit, which is, again, as I said, very cheaply done, and allows access to DCD organs that will increase, and has done so for the hearts at least to 25 to 40% increase in the volume of transplant that can take place. And that is very significant given the shortage of sensible donors. However, the logistics, how we go about this, where it should be done, needs very careful evaluation in India, because the downside of anybody just trying to do it with poor outcome means that we will then have a negative influence on people offering organs from even the brain dead donation pathway. So I'll leave it there, and hopefully some of these topics will come up for discussion. Thank you very much.
Thank you, Dr. Kumud Dittal, sir, for your excellent and insightful presentations. Now we will move to our panel discussions. I request both the speaker and both the panelists to join for a panel discussion. We will be focusing on a few important areas like NRP, obviously, retrieval, and Indian perspective, like a low resource setting. So, for my panel discussions, I start with the Dr. Ashish Sharma, sir. Sir, in your experience with an ex situ perfusion, that is a post retrieval, you do a post retrieval NRP. Against that NRP in situ, how do you find this approach regarding particularly logistic and practicality point of view?
So, I mean, when you're doing an uncontrolled DCD, so like the patient I showed that he did not have any recipients, we didn't have any recipients ready for it, right? So then you want to prolong the time for the organ to be on the machine, right? So you can't, I mean, the NRP is mostly done in the operating room, operation theater, right? And having a patient there doing NRP for 4-6 hours becomes very challenging, having the theater available for so long a time. Plus, we are actually not ready for NRP. Like, if I know that the patient's got an arrest, and if I do not have an ECPR protocol, I don't have it my institute. So in these situations, it is impossible to start NRP, right? Unless you are prepared. For a controlled DCD, it is possible that you're going to withdraw life support, patient is going to have a cardiac arrest. You can have all that infra ready for it, right? But otherwise, I don't think you have the NRP feasible. We have tried to do it in a couple of times, but getting all the personnel required for doing all this, it's not possible. You end up wasting your time. Whereas do a rapid retrieval, take out the organs, put the kidneys on the ice, so they are invariably usable. Livers we haven't tried so far, but I'm sure that if you are within that, we are mostly within that time period, that livers can also be used.
Thank you, sir, for your elaborated response. My next question is for Dr. Kumud Dittal, sir. Sir, just you have very well elaborated a difference between direct procurement and a TA NRP. So, as far as Indian context or low resource setting context is concerned, where the both the approaches where it stand from legal and ethical point of view and practicality point of view, both, sir.
That's a really important question because we need guidelines. Although, as you know, some of us here on the panel sit on the DCD consortium nationally, then several papers have been written. The third is in publication to guide clinicians really across the disciplines to understand about DCD and what is possible. And whilst, as you've just heard, trying to do an uncontrolled in a hospital implies pretty much to be able to be successful, you either have to keep those organs alive with some ex situ perfusion technology, which is very good for kidneys and perhaps even livers, but the liver machine at the moment is fairly expensive. And for hearts and lungs, that we don't have those machines without them costing an enormous amount of money. So, but a priori, we do need legislation that may be state derived in India that determines what it will allow in that particular jurisdiction. And without that, we can't really move forward because after that, it comes down to the hospital ethics committees. And as I've explained already, there has been a lot of debate about whether or not in the NRP setting, the head and neck vessels should be allowed to be clamped or not, or whether you should do NRP at all. Now, what is becoming clear is that if those centers, in one center in particular in the US, that is doing direct procurement and then putting it on ice and taking it back in the standard fashion and transplanting with good outcomes, then that will become probably the way to go. Although I'm fearful that that will take us back several years where we accepted heavy mortality and morbidity by claiming it to be part of the transplant process. And we didn't do the due diligence of testing functionality. And I think we will be required to test some level of functionality of hearts that have not shown any function since their circulatory arrest asystole, when they turn up in a big ball for the heart. The lungs I'm less concerned about, unless they're really edematous. The lungs will work, direct procurement will work very well, and we do not need to resort to any other form of in situ or ex situ perfusion.
Thank you, sir, for your response. My next question is for Dr. Soner Asthana, sir. Sir, now in India, we are doing an DCD program, but the majority of, in 99% of cases, it is just we are able to retrieve kidney only. So there is a big way to go. And now recently we have one liver transplant at Delhi also. So what are the, sir, road blockage and what are the challenges in expanding this program beyond kidney?
I must confess that I've been quite ambivalent about DCD for liver in India, primarily because of the reasons mentioned. I think that the kidneys are a lot more resilient in certain ways because we know that kidneys, initially when the DCD program started in the world, kidneys which had ATN would invariably recover. And then later on, we found that, of course, there was some impairment of function over the long term as well. In the livers, unfortunately, we did not have that option and we'd have to accept, primary non-function as an outcome, which is what Dr. Deital also alluded to, because we sort of accepted that as the cost of doing business. So in India, with the scenario was that one is that we have incomplete penetration of DBD. We only have 1,000 plus donors for 1.4 billion people. We have very poor primary and secondary care, which is necessary for maintaining perhaps victims of trauma or stroke, etc. Where we expect a large proportion of people to recover and a smaller proportion to perhaps become organ donors. And so, to a large extent, it looked like we were trying to pick fruits without actually, letting the tree grow, so to speak. So, for these reasons, I was not very keen on DCD in the Indian context. And also, given that India is a low trust society, doing something like a DCD outside the institutional context, like Dr. Ashish has done, might invite criticism as well as litigation, because families might sort of come up with the argument that we let a patient die, so to speak, to use their organs, and that would impact the entire program. That being said, I think that certainly in certain contexts, DCD has been useful. We have recently heard about the case in Delhi, and especially what has changed matters significantly is NRP. I think DCD with NRP is probably going to have outcomes as good as a DBD, and in some cases better as well, because most of our DBD donors are not very well maintained. The challenges are, again, as mentioned, one is we work in societies where controlled DCD is very, very rare. I think the Delhi case was an exception. And certainly, institution of NRP at the right time, in the right place, with the right equipment and the right team is going to be quite a big challenge. The second part is the factor of trust that I talked about, which leads to the question about whether families would accept withdrawal of life supporting treatment, whether they would understand it, and the possible negative repercussions of perhaps a family saying that organs were taken from somebody who was allowed to die. I think that those are probably two of the big limitations that I see happening. And the third concern, which is perhaps for later, is that certainly in the UK and the US, there is a perception that the growth of DCD has, in fact, cannibalized on the DBD program, which is because patients who would have progressed to DBD are now being taken up earlier for DCD donors because of reasons of convenience, for example. So I think that those are perhaps some of the challenges that are true for all organs, but more so the liver.
Yes, sir.
I mean, I'm happy to listen to Dr. Ashish and Dr. Kumud's views on the matter as well.
I would only comment on the last part you mentioned. That was a real concern early on as the DCD exponentially started rising, particularly in Netherlands, Belgium, UK, Australia. But retrospective analysis now shows that actually that they're not, as it were, cannibalizing the DBD, at least in those countries, on fairly decent analysis. I think it is a true utilization of DBDs and DCDs. And don't forget, in India, every Lama Dama is a potential DCD. at that a controlled DCD. The question is, how do we, as you rightly point out, despite legislation being in place, and not only through example, but through actual legislation passed 2 years ago, how do we convert that to an informed population, but more importantly, an informed professionals who are able to then practice, even in the Australian setting. I'll still never forget that even that first case, when I met the anaesthetist subsequently, the anaesthetist was concerned as to whether the death had been caused because of comfort care given during that withdrawal of life support. So there are a lot of issues at stake. What we know, if it's done properly, correctly, and that's where it's so important to have all of this written down, legislated, so that there can be no drawbacks, as you've outlined so eloquently. And I do think that eventually, in a state that has a good population that will understand, can be informed, with all those things that you mentioned that need to be in place, then I think it is actually possible in India to start in a limited way a controlled DCD practice, and then for it to hopefully spread.
Yeah, I think my views on DCD is like, see, it's going to, the withdrawal of life care is a
Can't hear Ashish.
You are not audible, sir. I think some connection issues there.
I mean, all of Dr. Dhital's points are very well taken. I think that certainly that if you look at DBD and DCD donors as a Venn diagram, then perhaps there is some overlap where certain donors who initially come in at GCS5 have not progressed to DBD, and perhaps those are patients who would fit into either pathway. But I mean, I agree that they are distinct populations. For liver, I think that to summarize, DBD with an NRP setting is probably far superior to a super rapid recovery. So that's probably my sort of comment.
Yes, definitely, sir. DCD with NRP is the way forward for liver transplantation. For my next question is for Dr. Chandrakant Mujewar, sir. Sir, you are part of a DCD team at AIMS Nagpur. So, main problem is that delayed graft function or non-functioning of the kidney, which is majorly impact the acceptability of a program overall. So, what strategies do you find helpful to reduce this delayed graft function or non-functioning of the graft?
Thank you, Dr. Amal sir. So, like, my take on this would be like whatever DCDs that we have done are uncontrolled DCD. So, moving on to controlled DCD program would be the one thing that would definitely improve our graft functions, use of NRP or machine perfusion. So, these will be the key takeaways for the DCD transplant programs.
Okay. Thank you. Dr. Ashish sir, you are you are discussing some things.
Yeah, I think I got disconnected in between.
Yes.
So DCD is going to come up at some point of time. So we just have to keep our anesthetist intensivist friends together with us. The most important thing is that I think it's going to happen at centers which have a fairly good bit of experience. So it is not a great idea that somebody who's not who's doing a brain death retrieval off and on starts doing a DCD. So I think you need to have some experience so that you have a team which can do it in a very rapid and certain way. And when this retrieval is happening, it's like a total chaos in the theater, like so many people running around. So at that time, noting down all the time. So one person has that responsibility in our team to note down the exact times. So all that is important because eventually, if you don't have the technologies to assess the organs later on, and you end up transplanting an organ which is not going to work, it's a big challenge for the recipient also, like having a transplant not working, giving all immunosuppression. So we need to be aware of all this.
Yes, sir. My next question is for Dr. Kumudittar, sir. Sir, what are the essential prerequisites you find in a center who want to initiate a DCD heart and lung transplantation, sir?
So, apart from what I said earlier on, which is to have the legislation in place, the hospital itself must have its own SOPs that have been practiced, and it needs an entire team that can work collegiately with the appropriate level of expertise. It is not a one-man show. That has just been explained again by my two colleagues. You really need all of this in place, practiced, before you can do it. Because, again, just to reiterate the downside of things going wrong, because not because of the organ or because of the recipient, but because of poor preparation or lack of experience or expertise, is that you will create a problem whereby the recipient, if things go well, could say, well, have you tested this organ? But has it ever shown any decent activity in the, for example, direct procurement without the machine perfusion? And that will become a really major problem because, as I said before, this has happened elsewhere when you bring in a new transplant technology, is that when there is a blip, downward blip, the donation of the normal brain dead donation rate, deceased donation rate, drops significantly. And India, already with its less than 1 million per population donation rate, can ill afford to have news or medical, even unintentional downsides create that negativity and affect everybody who are now recipients benefiting from that brain dead donation pathway.
You rightly said, sir. We need an SOPs and guideline in place before starting the program. Sir, for my next question is for Dr. Ashish, sir. Sir, what key lessons from your experience, sir, should new program adopt?
For DCD or for DBD? For
Yes, sir,
DCD.
DCD, sir, of course.
So DCD, I think you probably need to, maybe the ISOT can take a lead there, that you can organize these workshops, right? So people, I mean, you need to have that, you run through all those procedures and whatever roles each one of your team members is going to play. So unless you have that defined, I don't think you should venture into DCD. And at the same time, make your anesthetist, the intensivist, aware that if such a situation happens, that somebody who's on a brain death pathway, or the family who's been talking about organ donation, and that patient has a cardiac arrest, that has to be informed right away. I think that's what changes the context. I mean, if you're informed, then you can act.
Okay. Sir, my next question is for Dr. Sonal Asthana, sir. Sir, you, in your previous comment, you have mentioned many limitations, sir, for expansion of liver transplantation, DCD livers. So, sir, what solution, immediate solution in that already in the Indian context you suggest, sir?
Sorry, could you repeat the question? I lost you.
Sir, you have discussed challenges for an expansion of a liver transplant program. So, what immediate solution you want to suggest? How we start mitigating that challenges?
No, I think that I agree with Dr. Ashish in both the points that he said. That one is that teams that are probably familiar with the retrieval technique and teams that have done DBD in the past are probably better positioned in some way to do DCD because many of the processes are sort of in place, so to speak. And the other big thing is probably that we do not utilize the professional societies very well. And that is certainly true for ISOT as well as for the Liver Transplant Society of India, where I think our societies need to take a much more active role in mentoring centers that are looking to come up and develop SOPs for themselves as well as for the larger professional group, as well as perhaps even hand-holding programs and conducting mock drills, etc., so that we can learn from each other. So I think that while legislation is obviously very, very important, but developing professional SOPs and professional growth, for teams is something that our professional bodies perhaps need to do better. So I think those are probably 2 points that I would that can be addressed right away.
Completely agree with you and Dr. Ashish sir. Societies like ISOT, TSI, and all the professional societies can pitch in and form an SOPs and guideline. My last question is to Dr. Chandrakant Mujwar sir. Sir, you are working in a government setup. So, what changes you want from government side, or how can we do this in a government setup, sir?
I believe that in government setup there are challenges, but there are a lot of opportunities also. We have the highest number of patients who you find brain dead or who you can category 4 patients who you can consider doing DCD. So challenges or the things that I want from the system to be in place is like the administrative challenge. Often the administration is not in line with us considering the DCD. So there should be some clear-cut guidelines from the state governments since health is a state subject. So despite the legislation by despite the ruling by the Supreme Court, there is no legislation by the state government or no order from the state government to the authorities that, yeah, you can form a primary board, secondary medical board. Like for more than 2 years, we are doing uncontrolled DCD, but still we are not able to do a category 3 DCD just because we are not able to form a primary or secondary medical board. So this one thing I feel is the thing that is going to change a lot, at least for the institutions which are into the DCD program and which intend to do that.
You correctly said, sir. We need a collaborative effort of institutions, government, and societies. So this was a very well conducted, very good program, sir. Thank you. From on the behalf of ISOT, I would like to thanks both the speaker. I think sir want to say something, please.
Yeah, I just want I just wanted to discuss one thing with Ashish sir. Sir, using the this thing, the CRP, eCPR machine, or even during retrieval protocol, like to cannulate and start the perfusion, or even during CPR, we are starting the like we are pumping the heart, so we are perfusing the body. So it's like by dead donor rule, we should not perfuse the brain. So like I just wanted to know about your take on this.
So I think Kumal's already touched this. So so there are two ways to see this, right? So either, I mean, all those patients where we've done that CPR, so that's like an extended CPR, 30 minutes, 40 minutes, and you don't see any revival. So that's how we are certain that, okay, even if we are doing this, we are running the circulation. See, these are all category 4 patients. Category 4 means that they're brain dead, but technically we are not able to certify. So even if you do any circulation, your brain is not going to get any blood out of it, right? So whatever you do, the moment you stop that the CPR, the heart is going to stop there, right? There's nothing coming from the brain. So that way, I think it's fairly easy. You can do it. Second option, what you can do is that you keep on doing the CPR, take the patient to theater, stop CPR there for 5 minutes, and then declare dead there. So both ways, you are not violating the dead donor rule. So, like, we're not doing anything actively to hasten death, right? We are only stopping your CPR, which in any case we are going to do after 30 minutes. I mean, you can't keep on doing it forever, no?
Yeah, agreed, sir. So like even in rapid recovery of organs also, during that also you do that, you start the perfusion and then you clamp the supraciliac aorta, or you first take the control of supraciliac aorta and then you start the perfusion.
So no, we're not doing NRP. We're not being able to do NRP. Like it's, I mean, technically it's more difficult unless we don't have the eCPR thing at our hospital, right? So if you don't have the eCPR, then I don't think you will be able to do NRP in uncontrolled donations, right? Controlled, yes, you can. You can plan things, but uncontrolled, you cannot do. It's impossible to do that. So what we are using is that we take the organs out, then we put them on, like when we know there's a DCD thing happening. So same time we start to organize our normothermic machine perfusion. These organs are taken out, and then on the table on XC2 they are perfused. So that's like, it takes about at least a couple of hours to start all that. I mean, there's a danger of NRP if you're not doing it the right way. If you're not doing it the right way, if you're not measuring all those blood gases and all, so you will lead to damaging all the organs. No, it's a warm ischemia. So you can't take any chances there.
Thank you, sir.
Thank you, sir. I would like to, on the behalf of ISOT, I would like to thank you, Dr. Ashish Sharma, sir, Dr. Kumud Dittal, sir, Dr. Chandrakant, sir, and Dr. Sonal Asthana, sir. Thank you, Dr. Sanjay Kolte, sir, for guidance. And thank you all participants for your enthusiastic participation. And I would like to thank you all and good night. Thank you.
Thank you.
Thank you. Thank you.
Thank you.
Thank you, sir.